resistant hypertension and role of moxonidine. And we have none other than Dr. R.B. Sudagar Singh, who will enlighten us on this topic. And sir is currently the chairman for Quality Improvement and Patient Safety Team. He is the professor and senior consultant of general medicine at Sri Ramchandra Medical Center at Chennai. And sir has numerous publications and sir has been the principal investigator of number of trials. His area of expertise are teaching, curriculum development, clinical and administration. With this, I welcome Dr. Sodagar Singh and hand over the proceedings to him.
Thank you. Thank you, Amit. At the outset, I would like to, thank the entire team of McLeods who have probably arranged an excellent webinar at this beautiful evening in Chennai. And people who are not from Chennai, I think the climate is extremely pleasant and good. So with that small note, I will start my presentation. Is my slide visible?
Yes, sir, visible.
Yeah. Do we have participants logging in, or can we go ahead and start?
Sir, you can go ahead and start.
Okay, excellent. So, good evening, one and all. Today and this beautiful evening, probably we'll just, brush through some of very focused area of hypertension management. You all are very, senior physicians who have been dealing with management of hypertension in your day-to-day practice, and your clinical exposure should be enormously wealthy. But still, there is a small area of hypertension where there is some inertia, either from the patient side or from the physician side, to optimally control their hypertension targets. So today, probably we will be going through resistant hypertension. Before going into resistant hypertension, let us look at what hypertension itself means to us right now. Hypertension is though the hypertension has a multifaceted presentation and complications, it is a very, very easy disease to be diagnosed. You don't need any fancy gadgets to make a diagnosis of hypertension. All you need is a simple outpatient equipment, which is none other than the BP measuring equipment, sphygmomanometer. But in spite of this simplicity in making a diagnosis of hypertension, still hypertension remains a largely an undetected disease. But even if to a certain extent, because of the raising awareness among the doctors and the patients, even if it is diagnosed early, most of the patients are not adherent to the medication, and they are not at all on any medicines to control their hypertension, because most of the time this disease is asymptomatic. And there is a major portion of our patients who have been diagnosed appropriately with the diagnosis of hypertension, and they are started on medication, but they do not achieve optimum control with the existing drugs which they use. Why is hypertension so important? It has been shown from the HOT and the UKPD's trial that just by aggressively controlling the BP to near normal, to a magic number, you can very significantly reduce stroke, myocardial infarction, and heart failure. If you look at these three major macrovascular events, heart failure, you can reduce to more than 50%. If you look at the other side of the coin, if you have 100 patients presenting to you with cardiac failure, your outpatients or in the hospital setting, most of this heart failure patients, the one and only important risk factor which they have is hypertension. So just by controlling hypertension to the optimum level, we can prevent major chunk of people developing cardiac failure. So routinely, what are the drugs we have? Conventionally, we know that we have angiotensin receptor blockers, ARBs, beta blockers, calcium channel blockers, and diuretics. These are the main four major classification of drugs which we use for hypertension. It is only an arbitrary selection of your antihypertensive drugs, but this selection of drugs predominantly bases around the coexisting morbidity and other risk factors which the patient has at the time of presenting with high BP. Young people who do not have any of the risk factors when they present with high BP, say less than 55 years, our choice of drug is usually an AC inhibitor or an ARB, probably beta blocker to a certain extent. But the same, if the patient presents with more than age of 55, then we tend to choose calcium channel blockers and diuretics. I'll let you know why this preference is there during my later discussion. But this is only a first step. If you start a single monotherapy and if you're not able to control this, hypertensive patients, then you move on to adding add-on therapy from other class of drugs. But before adding on from the other class of drugs, we should probably optimize the dose of the initial monotherapy which we have started. Unless otherwise, we have up-titrated our initial drug to the maximum tolerable limit, please avoid adding or add on to the second drug, moving on to the second drug. Because most of the time, when patients are put on the optimum dose of a single drug, most of them do achieve a target BP level. But if they don't achieve with your optimum level, then you can add on other class of drugs like beta blockers, calcium channel blockers, and diuretics. There are some preferences. If you think that the patient has other risk factors like diabetes, dyslipidemia, and these people have high risk of developing cardiac failure with a lot of remodeling happening in the heart, then your choice of drug is usually an AC inhibitors or ARBs, followed by a diuretics, and then beta blocker, and probably calcium blocker to the last. Why I am putting the calcium channel to the least is, though calcium channel blockers are very potent antihypertensive drugs, it has not been well proved that calcium channel blockers do not really have any mortality benefits. Definitely, they have very good role to play and a significant role to play in optimizing the BP control. But if you choose two class of drugs, calcium channel blockers with other class of drugs, probably if you're able to achieve good BP control with other class of drugs, then that is more than that has an additional effect on improving the morbidity of and mortality of the patient. What are the limitations of the present therapy? In spite of using all these drugs, as I have discussed, we are not able to achieve the target level of BP in many of our patients. And sometimes, even with a very low dose of a monotherapy, patients do not tolerate the drugs. So if they start having side effects to a particular class of drugs, you have no choice but to stop that class of drugs and move on to another class of drugs, where you have to start from a lower dose and up titrate. And then if you're not able to control with one class of drugs, you might have to add another class of drugs. So what is resistant hypertension? So it is very difficult to label somebody as resistant hypertension unless otherwise you have meticulously followed each and every small details of the patient's treatment and his adherence and other coexisting risk factors and other medication and his lifestyle. So you have to completely analyze the entire scenario surrounding the patient before making a diagnosis of resistant hypertension. So resistant hypertension is conventionally defined as if the BP is not achieved to a target level in spite of taking 3 antihypertensive drugs. Those 3 antihypertensive drugs should be from 3 different classes. You cannot have 2 beta blockers or 2 calcium channel blockers and expect a good BP control, because you need to have a multi-pronged approach to control your BP. You need to have almost 3 classes of drugs, and some textbooks also say that one of them should be a diuretic. Okay, so if you have three classes of drugs with optimum dosage, and still if you're not able to achieve a target BP of 140/90 or 130/90, then you call it as resistant hypertension. There are a lot of causes or etiology for this resistant hypertension. Let us look at what is probably the causes for resistant hypertension in our population. If you look at the epidemiology, uh, though resistant hypertension is well known and described, exactly we don't know the number of resistant hypertension uh, in our population. The simple reason is it is very difficult to probably diagnose resistant hypertension. As I told you, you need to fulfill all these criteria. The patient should have been in three classes of antihypertensive to the fullest dose, and the patient should be absolutely adherent to their drugs, and his lifestyle should have been modified with no other drug interaction which is causing hypertension. So unless otherwise you prove beyond doubt, it is very difficult to make a clinical diagnosis of resistant hypertension. Hence, there is probably a lack of knowledge on the prevalence of this hypertension in our community. In a recent analysis in the National Health and Nutritional Examination Survey, participants being treated for hypertension, there's only 53% were controlled. So what happened to the rest 47%? Do you mean that the 47% have resistant hypertension? We don't know. That is a number where the BP is not controlled. But out of that, there could be a lot of reasons why the BP is not under control. They may not be really resistant hypertension. In an antihypertensive and lipid lowering treatment to prevent heart attack trial, that is the ALA trial, which is a very famous trial, after approximately 5 years of follow-up, 27% of the participants were on 3 or more medication. What does this indicate? This indicates almost 27% of our population who are hypertensive do require more than 2 medications to control their BP. So if you do not use more than 2 class of drugs in your hypertensive population, it indirectly means that almost 27% of your patients would not be under good hypertensive control. So let us come to the etiology of this resistant hypertension. As I told you, before making a diagnosis of resistant hypertension, we should look at these clues to see whether why this BP is not controlled in a particular patient. It is either a suboptimal therapy, which means that the dosage is not adequate choice of drugs is not there, or the patient is not probably adherent to it. Extracellular volume expansion. You may be giving them adequate antihypertensive drugs, but for some reason, like a borderline renal failure or a congestive cardiac failure, if you fail to use a diuretic in these kind of patients because of the extracellular volume expansion, even if you use adequate antihypertensive dose, the BP might not be under good control. Poor compliance to the medical and dietary therapy. In spite of adequate patient education, patients do not adhere themselves to the adequate therapy. More so when they are on multiple pills. They may think that they are already taking 1 or 2 drugs for hypertension. Why take another extra drug for hypertension? And they may skip the third one. So you need to educate them, saying that each and every drug plays an important role, and taking all the 3 drugs continuously and meticulously is mandatory to make the BP under good control. And there is a small set of group of people who may have secondary hypertension. These secondary hypertension, in coming slides, we will also analyze what are the causes for secondary hypertension. When you have secondary hypertension, it is very, very difficult to control these people for their hypertensive control, because some drugs can paradoxically increase hypertension. Some drugs do not work in some classes of secondary hypertension. So you might have to skip those drugs, and you might have to optimize other group of drugs. So looking for any correctable or secondary cause of hypertension and clearing them will improve the BP control in these kind of patients. Office or white coat hypertension, very popularly called as white coat hypertension. These people have very high BP on an office recording basis, whereas when they do a home monitoring of BP, usually their BP is under very good control. So we need to keep in mind So before up titrating your antihypertensive drugs, make sure that you're not dealing with white coat hypertension, because if you're going to increase your drugs, missing this white coat hypertension, they may start developing very severe symptoms secondary to overdrugging, like postural hypotension and other things. So you should be very careful, and you should always keep in mind this white coat hypertension. What is pseudo hypertension? Pseudo hypertension is nothing but an erroneous measurement of BP. Either the cuff is not all right, or there is a stiff arterial wall, or there is an arterial disease which causes an hypertension. So we need to keep in mind whether our BP recording is very, very correct. Ingestion of substance that can elevate the BP. So it is conventional teaching that people who take caffeine or smoking, usually they have a temporary or a transient rise in their BP when they check immediately after, when they take a caffeine, or when they have had a nicotine smoking happening in the recent time. So what you have to do is there should be a free period, almost 2-3 hours after a caffeine intake, or they should have a smoking free period before checking the BP. Ideally, we should ask them to stop smoking, because one of the important lifestyle modification expected from an hypertensive patient is quick smoking and moderation of alcohol. Sometimes, because of the serious side effects of the antihypertensive drugs, these people stop this drug without the knowledge of physicians. And these are some of the problems from the patient side. Sometimes what happens is there is an inertia to increase the dosage. There is an inertia to increase the dosage of antihypertensive from the physician side. So we should know what is the upper limit of the dosage for a particular class of drugs or a particular drug per se, because unless otherwise we titrate them to the optimal therapy, we may not able to achieve the desired goal of BP. So whenever you start a drug, you should probably optimize, increase it to an optimal level, titrate it up to a level where the side effect profile is the minimum, and then probably assess the patient periodically and do. Probably a thumb rule is to look at the half-life of a drug and titrate the drug on a periodic basis. Some of the drug would probably you can titrate as early as on the 5th day or the 7th day. Some drugs need a longer time, probably more than 2 weeks, 3 weeks before you can attempt to increase the dosage of a particular drug. So you need to give a lot of time to these patients, analyze them, slowly step up the dosage of the drugs periodically, and reassess them and reassess their complaints, and then find whether they are on optimal therapy. In spite of their optimal therapy, they are still devoid of adequate control. Extracellular fluid expansion, as I already told you, apart from high BP, if somebody has for various reasons an extracellular volume expansion, then this adds on to the poor hypertensive control in these people. So the most common causes for this extracellular volume expansions are, there could be a borderline renal insufficiency, not an overt renal failure, but a renal insufficiency causing extracellular volume expansion. Sodium and sodium retention due to vasodilator. Some of the drugs which we use as an antihypertensive can also produce vasodilatation causing sodium retention and extracellular volume expansion. Ingestion of high salt diet and the presence of clinically occult expansion, which means that you may not be able to find out they have peripheral edema. The volume expansion can be central. They can have pulmonary edema, or they can have other interstitial space volume expansion. Use of once short-acting loop diuretics sometimes cause reflex extracellular volume expansion. Gradually removing this fluid probably help in better control of BP. So let us look at what are the poor compliances which leads on to poor BP control. Up to 80% are at least partially non-compliant. If you look at people who do not have good BP control, 80% of them do not take their drugs appropriately. Lack of knowledge about the disease. People do not take hypertension very seriously and do not adhere to the drugs, because Mostly these hypertensive patients are asymptomatic and they do not have any symptoms. Unless otherwise they have severe headache, they do not reach the physician, start taking drugs. And once the headache subsides, they think that they are cured and they stop medication. Cost. I mean, some of the medications are definitely expensive, and taking it lifelong puts a lot of challenge on the patient to closely adhere to their regimen. Complex dosing. So if you ask the patient to take one particular hypertensive, which is short acting, which has to be taken twice or thrice a day, and one antihypertensive, which has to be taken once a day, or multiple dosing and multiple pills, puts a lot of confusion on patients, that to elderly patients. So preferably, I mean, choosing a drug with longer half-life so that you can space it at once a day, and combination pill also helps in probably circumventing this particular poor compliance factor. Patient education, rescheduling the missed appointments by the patients, and following up these patients to adhere to their regular follow-up and BP monitoring. Simplifying the drug regimen is an important, strategy which we have to follow. Monitoring of drug intake, like pill count. Elderly people, geriatric people are usually advised to bring their empty tablet cartons to see whether they have finished the 30 days course completely without missing, and any psychological challenges which they have. These things has to be looked into clearly, so that correcting that probably can improve the complaints and improve the BP control. Uh, as I told you, the most important lifestyle modification probably we suggest for an hypertensive state away on diagnosis is they need to optimize their weight. If they are overweight or on the obesity side, probably they should be educated on the optimal BMI, and they should start an aggressive diet regimen and appropriate exercise scheduling to bring down their weight, I mean, very gradually to reach an optimal weight. Low salt intake. Though most of the studies have not clearly proved that only targeting the salt has very, very marginal effect on the BP control, but still, salt restriction plays an important role because it can aid in reducing the extracellular fluid, volume expansion, which also can improve the dosage, improve the antihypertensive effects. Alcohol intake has to be limited and smoking has to be completely stopped. There is no moderation in smoking. Alcohol, though, can be moderated. Once we have identified these are some of the main reasons for somebody to have a resistant hypertension or an uncontrolled or not optimally controlled hypertension, we should start looking at people who have secondary hypertension. Up to 11% of the patients with refractory hypertension have been identified to be having secondary hypertension. The most common are renal artery stenosis and chronic renal parenchymal disease. So renal system plays an important role in probably contributing to secondary hypertension. Probably a thumb rule to probably suspect secondary hypertension is if you identify or if you pick up somebody very, very young, less than 30 years with very high presenting BP, think of a secondary hypertension. Rule out secondary hypertension before starting him or calling him as essential hypertension. The second category of patient is somebody who is on good control BP on antihypertensive for prolonged course of years, but suddenly starts going out of control. Think of a secondary hypertension. People new onset hypertension after the age of 65, 70, think of renovascular disease in these kind of people. So extremes of age suspect, and suspect on a group of people who have already been on good control suddenly loses their control in spite of adequate and optimal treatment, do not get under good control. Think of secondary causes of hypertension. We no longer call essential hypertension. We call it as primary hypertension. We have taken away the usage of essential hypertension. If you look at the history of hypertension, why this essential hypertension came into vogue is there was a period, what I'm talking is almost 18th century BC, when initially they found out that there is a condition where your normal BP can be elevated. They thought at that time, and they even published a lot of papers saying that this high BP, secondary to either renal cause or cardiovascular cause or age, is mandatory to maintain adequate cardiac output. So they felt that they were convinced that a high BP they thought was essential to maintain a good cardiac output in these people, and hence you should not tamper this high BP to bring it down to normal level, which can be deleterious in its effect. That is why they said it is essential hypertension. Essential hypertension means it is definitely required for that person to maintain cardiac output. Later, it was disproved that this is not essential hypertension because that high BP produces a lot of serious adverse effects and organ failure. So that essential hypertension was given away, and we have started using the term primary hypertension, and other causes which leads to hypertension, we call it secondary hypertension. Let us look at renovascular hypertension as such. Well-controlled hypertension has recently become, I told you this, because when you have a good controlled people, hypertensive people suddenly losing control, you should think of a secondary hypertension. Any renovascular cause, sudden onset of an atherosclerotic plaque in the renal artery, or some renal artery aneurysm causing blockage, or a renal parenchymal disease causing this resistant hypertension. They're all, I mean, usually in older days we used to do capital induced renogram, but nowadays a good renal artery Doppler is a simple non-invasive mechanism to find out any renal artery disease. If we have bilateral renal artery disease, you all know that we are straightaway devoid of all angiotensin receptor blockers and ACE inhibitors drugs from their basket, because that is going to cause a paradoxical high BP. So you are devoid of such drugs for these kind of people who usually present with very, very high BP. Primary aldosteronism. 5% of the patients with refractory hypertension do have this primary aldosteronism. The aldosterone-renin ratio is usually a good screening mechanism. So if you suspect somebody having primary aldosteronism, then look for this ratio and find out whether these people are, having secondary hypertension. Regardless of whether the patient have an adrenal adenoma or idiopathic aldosteronism, they respond to aldosterone blockers, antagonists, which is a specific drug to specifically target this kind of secondary hypertension. That is why I told you, if you give if you select other class of antihypertensive in these subgroup of people, if you have not identified that they have a hyperaldosteronism, then you may miss treating this patient optimally with aldosterone antagonist. Pheochromocytoma, you all know pheochromocytoma is a very, very dramatic disease where there could be a swinging BP. They can have suddenly hypertensive emergency. They can have very high BP with tachycardia and sympathetic overdrive. And a good screening test would be a urine metanephrine. And usually they respond well to both alpha and beta blockers combination drugs. We have probably spent a lot of time on office and white coat hypertension. See, the one clue is when you have people with high BP at your office, and when you titrate the drug, and when they go home and they start complaining they have lightheadedness or postural dizziness, or they have typical symptoms of postural hypertension, think that probably there is a difference in BP monitoring at their home and in the office. And ambulatory monitoring probably will help to get a clue on whether they really have a office or a white coat hypertension. 24 hours ambulatory BP monitoring is an excellent tool to identify whether these people have office or white coat hypertension. And you can also exactly probably time your antihypertensive drugs based on this 24 hours ambulatory BP monitoring. Some of them do have very high surge in BP during their active day of work, or some of them will have very high BP or uncontrolled BP during their late hours or early morning. So sometimes these also, apart from identifying white coat hypertension, gives us a clue how we can time our antihypertensive. Timing it correctly can probably, offer the patient a 24 hours smooth and a very excellent BP control in these kind of patients. So what is the prognostic value? As I said, refractory hypertension defined as despite having 3 drugs, the diastolic is more than 100, and you have to bring it down to less than 80. So somebody who has a 24 hours BP monitoring and their diastolic BP is close to 100 or more than 97, usually they have very bad prognosis if you do not control their BP adequately. Pseudo hypertension, I told you, old patients with thickened calcified arteries. it is very difficult clinically to identify whether they really have pseudohypertension, because you need to have an exact intra-arterial measurement of BP to prove that your BP, office BP monitoring is pseudohypertension. So without exact measuring of the arterial BP, it is very difficult to say pseudohypertension. It is only theoretically we can probably conclude that some of the old patients who have isolated systolic hypertension but are asymptomatic, and if you increase the antihypertensive in spite of your adequate control, the systolic BP does not come down, then probably you think of a pseudo hypertension, and you don't have to aggressively treat them or with multiple drugs to bring the isolated systolic hypertension, which probably is due to pseudo hypertension. Improper, with this we have already discussed an improper blood pressure measurement, because nowadays we have a lot of home measuring equipments. Appropriate, the cuff size is very, very important, and placement of cuff is also equally important. And if you do not teach them how exactly they have to measure their BP at home, usually people get panicked with erroneous measuring at their home and come rushing to a hospital, where if we check, the BP will be very normal. So even in our OP setting, we should also train people who are taking BP measurement in our OP basis, so that they have adequate knowledge on correct BP measurement. Then these things probably you know that there is a challenge on identifying this pseudo hypertension. This we have already discussed, except that we should also go through some of the drugs which the patients are taking. A good physician will always look at the prescription from other doctors, even though it is not meant for their antihypertension, because most of the other drugs given for other reasons usually interact with either the treatment offered by us or has a direct impact on the health status of the patient. One such drugs are oral contraceptive pills, anti-inflammatory drugs, and symptomimetic agents which they give, steroids, some of the cognitive function boosting drugs, and some alternative drugs. Of late, there has been an increased use of alternative drugs, which also has to be kept in mind before probably branding them as pseudo hypertension or resistant hypertension, because you should review that, and unless otherwise these other drugs are mandatory, we should ask the patient to discourage in using these drugs. What are the other major clinical conditions which can probably cause a resistant hypertension? This is obstructive sleep apnea syndrome. Obstructive sleep apnea syndrome is probably a well-focused disease, which is probably started unfolding its various presentations in nature, where they can present with obesity, high CO2 retention, and they can also present with part as a syndrome X. So there is multifaceted presentation of obstructive sleep apnea syndrome, where we need to keep an eye on these patients, because they may have very, very resistant hypertension, and usually they are not amenable to one or two drugs which you use routinely in your practice. Chronic disease, chronic kidney disease patients also are very resistant to antihypertensive drugs. Primary and secondary hyperaldosteronism, severe atherosclerotic disease, calcification of the arterial wall, elderly subjects, as I told you, or sometimes renal vascular disease also are very resistant to antihypertensive drugs. Aortic valve sclerosis and hemodynamic significant insufficiency. So aortic regurgitation itself produces a major challenge. Aortic regurgitation in elderly due to secondary to degenerative valve disease causes a hyperdynamic circulatory state, where the volume is so high and there is a huge pulse pressure, and the systolic and diastolic variation is so high, and these kind of people very poorly respond to antihypertensive, because the systolic BP is always very, very high. This is just a flow chart, though it is little congested. This slide probably we'll just go through, which we have already seen. This is nothing new. NSAIDs, how does it produce a sustained high BP? How other drugs like glucocorticoid, cyclosporine, and erythropoiesis stimulating agents, these elicit substance abuse. These are some of the other class of drugs we should keep in mind to find out whether they have very high BP secondary to this kind of drug intake. So if you, this is a flow chart to just tell you how exactly ultimately it causes a high BP. There are only three mechanisms by which it can cause high BP. One, uh, salt water retention, renin-angiotensin system, reduced nitric oxide level, and probably CNS activation. Probably today we will probably look in detail about CNS activation, where probably suppressing the CNS stimulation of the sympathetic outflow has a very beneficial effect on BP control. Sympathetic overactivity. Probably we have narrowed down from all the other pathologies. We have come to look at our area of interest today of sympathetic overactivity being a central feature linking of hypertension, other components of metabolic syndrome. So now they have identified that diabetes, insulin resistance, obesity, for that matter, even obstructive sleep apnea, all this is a cluster of symptoms or disease process which probably either secondary or probably uh, either it is secondary to sympathetic overactivity or might lead to sympathetic overactivity. Whether sympathetic overactivity causes all this problem or this problem leads on to sympathetic overactivity, one thing which we should understand is these set of people will definitely have sympathetic overactivity. So unless otherwise you take care of this sympathetic overactivity, adequate BP control is going to be a real challenge. Linked with hypertension. In animal models, sympathetic overactivity can be initiated and maintained. It can initiate and maintain elevated BP. So if you just stimulate the sympathetic system in the CNS, there is a sustained BP elevation in these animal models. In humans, plasma norepinephrine levels in hypertensive patients are significantly higher than in normotensive. So they have found out very significant, basic science finding where the norepinephrine levels are quite higher in hypertensive people than in normotensive, which probably, as I told you, whether this norepinephrine is causing this high BP or this high BP is causing an increased sympathetic outflow, we are not sure. But by reducing the sympathetic outflow and bringing down the norepinephrine level, definitely that would be a good chance that the BP also can be brought under good control. Sympathetic activation is seen in elderly phases of hypertensive and may proceed to blood pressure. So this is called a pre-hypertensive state. Even before the clinical manifestations of BP, high BP happens to patients, there is a period where there is only a sympathetic hyperactivation is happening. So when you follow these people with sympathetic hyperactivation, later on these people move on to develop a high BP and they sustain to become an hypertensive in the future. Sympathetic activity can be high in young subjects with borderline hypertension. So here, this sympathetic activity has been associated with young hypertensive who have borderline or high hypertensive. So if you identify these kind of young people who have a high BP, and if you find that they have a very high sympathetic activity, and it is imperative that you start treating these people even if they are young in age and even if they have a very borderline high BP, because unless otherwise you reduce the sympathetic overactivity, it is going to behead the hypertensive crisis. So one leading on to another, it is going to become a vicious cycle. So you need to break the cycle by reducing the sympathetic activity. This suggests that the increased sympathetic activity is the cause rather than the consequence of a blood elevation. So the two things which we saw, that pre-hypertensive phase itself, the sympathetic activity is increasing a group of people. And here, even in young people with very borderline, there is a high sympathetic activity. So there is evidence that this sympathetic overactivity could be probably the cause for hypertension rather than hypertension which leads on. But there are evidence to prove that even prolonged hypertension can cause sympathetic hyperactivity. There is also a study, I don't remember exactly, but they say that hypertension begets hypertension. When you label somebody as hypertensive people, and this hypertension itself makes them have a sympathetic overactivity, and that worsens the hypertension, and this becomes a beget, and this becomes a vicious cycle. Linking with obesity. So we have found out that this obesity itself is probably a risk factor for hypertension. And along with the risk factor of being an hypertension, these obese people do have high levels of norepinephrine, which clearly shows that probably obesity through its sympathetic overactivity probably causes hypertension. So it is imperative that you arrest the sympathetic flow to bring down BP in these group of people rather than choosing other drugs, because this makes logic that the cause for hypertension and obesity is predominantly sympathetic overactivity. Linked with insulin resistance and diabetes, sympathetic activation is a major component of insulin resistance in clinical experiment and in humans with type 2 diabetes mellitus. As I told you, we had a constellate of disease: obesity, type 2 diabetes mellitus, dyslipidemia, hypertension, cardiac failure, and all those things. If you look at all those things, probably the cornerstone somewhere or other, whether it is a cause or an effect, the sympathetic activity plays a role in probably worsening or initiating the disease process. Cardiac autonomic dysfunction occurs in 30 to 50% of the patients with diabetes, 40% of the obese patients without diabetes. If you look at very carefully, a cardiac autonomic dysfunction occurs in 30 to 50% of the patients with diabetes, which means that there is some kind of a sympathetic dysfunction. And 40% of the obese people have this kind of dysfunction without diabetes. So if you compare obesity and diabetes, it looks like almost the same amount of effect the diabetes is going to have on hypertension or sympathetic system. The obesity itself per se as a single risk factor can have on the system. Linked with other risk factors, sympathetic overactivity is also implicated in renal disease, left ventricular hypertrophy, and congestive heart failure. Left ventricular hypertrophy is very, very crucial because this left ventricular remodeling probably is the beginning stone or the stepping stone for cardiac failure. Once there is some kind of a microvascular or macrovascular damage to the myocardium starts remodeling. If you do not stop the remodeling or revert the remodeling, these remodeled cardiac function is so ineffective that they may proceed to become congestive cardiac failure patients. So how do we make a diagnosis of true hypertension? If you think that in spite of adding 3 antihypertensive drugs, which probably also includes a diuretics to the fullest tolerable dose, if the BP is not under adequate control, think of resistant hypertension. In resistant hypertension, you need to know whether it is true resistant hypertension with the 24 hours BP monitoring. If the BP monitoring is normal and if you could see only hypertension during your office visit, then probably there ends your investigation. All you have to is reassure the patient and look at an optimum environment for checking BP. Then if all the above BPs, even the ambulatory BPs are all above, then you need to think of resistant hypertension. See whether the patient is adherent to the drugs. Assume that the patient is not taking any other drugs which can interfere or any substance or for that matter smoking or excessive alcohol abuse has to be interviewed. Then the possibility of secondary hypertension should be kept in mind. When all those things are ruled out, then probably you should think of resistant hypertension. Why we need to spend so much time to identify this resistant hypertension is you need to use other class of drugs like centrally acting drugs to probably treat these group of resistant hypertension, because in spite of your adequate 3 group of drugs, if you are not able to control, look for secondary resistant hypertension and start using centrally acting drugs, which is probably the treatment strategy. Autonomic dysfunction appears to have an important role in many of the patients with metabolic syndrome. So when you narrow down to resistant hypertension, major chunk of these resistant hypertension people do have one of these parameters, like they are on the metabolic syndrome, they are obese, they have sleep apnea, they have diabetes, they have other metabolic diseases, which probably predisposes them to high sympathetic activity. So in these group of resistant hypertension, it is probably logical to start a drug which can interfere with this sympathetic hyperactivity. What is the therapeutic goal? Given the adverse effect of sympathetic overactivity, which we have seen in a couple of slides earlier, and the development of complication, reducing the sympathetic overactivity should be the primary goal of non-pharmacological as well as the pharmacological therapeutic strategy. So what are the non-pharmacological way? Lifestyle modification, meditation, calming down, behavioral therapy, a lot of things are there. In this fast world, I don't know how far we can probably give importance to these kind of non-pharmacological mode of treatment, though it is very, very important. And as a physician, we should probably impress upon our people to start these kind of non-pharmacological mechanism to bring down the sympathetic drive. Plus, we need to seriously look at centrally acting drugs which can reduce the sympathetic outflow. So let us briefly, in the next couple of slides, will go through what exactly is central sympathetic outflow. The hypothalamus and the brainstem is the main organ which controls the sympathetic nervous system. A stressful stimulus are transmitted from the sensory cortex to the hypothalamus and finally to the rostroventrolateral medulla. In the rostroventrolateral medulla is the final common pathway for a number of descending influences of the sympathetic nervous system activity in response to a stimuli like stress, hypotension, exercise, pain, and whatnot. Whatever stimulus, ultimately the rostral ventrolateral medulla is the one which gets selective blockers of the central nervous system outflow at the RVLML prevents the deleterious effect of this peripheral sympathetic nervous system or its overactivity. Stimulation of an alpha-2 adrenergic receptor and I1 receptors in the RVLML reduces the sympathetic. So the idea is to, if you stimulate the alpha-2 blockers and I1 receptors in the RVLML, reduces the sympathetic outflow to the periphery. So we have to have drugs which can either stimulate the alpha-2 or the I1 receptors. So this basis is for the centrally acting drugs. So our first generation of drugs which preferentially acted only on the alpha-2 or alpha-2 agonists were clonidine, guaifenesin, and methyldopa. These are drugs which are very effective. It are very effective in reducing the central sympathetic outflow, easily crosses the blood-brain barrier, good bioavailability. But the only problem is they have a lot of side effect profile. The second generation drugs which preferentially blocks the I1, which preferentially stimulates the I1 receptors or I1 agonists. These are moxonidine and reluminidine. So these two drugs are probably which acts different from your first generation of centrally acting drugs. Let us see how it acts differently. What is the alpha-2 receptor stimulation and causes? It causes, though it reduces the sympathetic outflow, it produces excessive sedation. So the first generation of central sympatholytic reduces central sympathetic outflow by stimulating the alpha-2 adrenergic receptors in the RVML medulla. But they also stimulate the alpha-2 receptors on the locus coeruleus and causes sedation. So this drug does not only act in medulla, but it also acts in the locus coeruleus, which is the area of sedation. So if this drug acts on either side, on one side it can reduce the sympathetic activity, thereby bringing down the BP, but usually it causes sedation. If it is used at the night time, probably the effect can be nullified, but these drugs cannot be, has a potential disadvantage of very difficult to use during daytime. The other side effects are dizziness, lightheadedness, drowsiness, dry mouth, constipation, and rebound hypertension. So these are other some side effects of centrally acting, first generation centrally acting drugs, which predominantly stimulates the alpha-2 receptors. Let us look at the newer centrally acting drugs, which specifically stimulates the imidazolin receptor. Drug which selectively stimulates the imidazolin receptors in the RVLML also reduces the central sympathetic outflow. It produces similar effect like your first generation, like stimulating the alpha-2 receptors. But only thing is, it does not stimulate alpha-2 receptors, or it does not stimulate any other receptors in any other part of the brain system. So it has least side effect profile. So our drug of, probably importance here on discussion for today is moxonidine. It is 200-fold more selective for the imidazolin receptors. So it stimulates the imidazolin receptors almost 200 folds more than your other centrally acting drugs or other alpha-2 receptors. So it preferentially goes to the imidazolin receptors and it bypasses or it neglects the alpha-2 receptors, thereby reducing the side effects. Moxonidine preferentially stimulates only the I1 receptors present in the RVLML. So it does not stimulate the imidazolin receptors that are present anywhere else in the brain. It decreases the central sympathetic tone, causing a decrease in the systemic vascular reduction and reduces the blood pressure. So all the other probably the effect is same as centrally acting drugs. Only thing is the action by moxonidine is from imidazolin receptors, unlike other drugs which through the alpha-2 receptors. Role of sympathetic nerve activity in ESRD patients. The role in hypertension, monotherapy in comparison with other antihypertensive have been studied, and also in combination therapy. So when you look at moxonidine, it can be used as monotherapy. I told you some of the compelling indications. Somebody who is very obese and a type A personality, who you know that probably has a sympathetic hyperactivity, very young people, probably a centrally acting drug to choose as first line itself, probably you are justified. Combination, you can do combination with any class of drugs with moxonidine, and the role in obese and elderly uncontrolled hypertension we have already seen, and it also has some pleiotropic effect. Amit, am I crossing my time limit? We have a lot of slides to go.
Sir, please proceed, sir. We have time, sir.
Okay, fine. Thank
you,
you,
sir.
So if you look at this slide, there is an acute effect of moxonidine and placebo on sympathetic nerve activity in hemodynamic and hemodynamic measurement in end-stage renal disease. If you look at end-stage renal disease patients, they have a high sympathetic outflow activity. So these resistant hypertension in ESRD, they compared moxonidine with placebo. So what placebo was not able to achieve in reducing the sympathetic activity in this end-stage renal disease patient, moxonidine was effectively be able to reduce the sympathetic outflow, thereby giving very good BP control in these kind of end-stage renal disease patients. This is the duration. Probably immediate. There was a serial measurement of both BP and the sympathetic activity. On a prolonged usage, definitely there was a blunting of the sympathetic response and activity, these subgroup of patients, which also translated into good BP control also. It didn't only reduce the sympathetic outflow, but it was evident in clinically by way of reduced BP in these kind of people when compared to placebo. Yeah, but now we can say that when a drug is compared to placebo, definitely the drug has to be better than a placebo. But this drug cannot be compared with any other antihypertensive because no other antihypertensive drug has a similar centrally acting sympatholytic, either a beta blocker, calcium channel blocker, or for that matter, ARB or AC inhibitor. So this sympathetic outflow activity has been compared with placebo to prove beyond doubt moxonidine has a clinically significant reduction in the sympathetic outflow, thereby translating in way of benefit as BP reduction. So in end-stage renal disease patients, low-dose minoxidil produced sustained and substantial reduction in the sympathetic outflow without hemodynamically compromising them. Okay. I don't know, there is a blank slide here, but anyway, in a well-designed 8-week trial, monotherapy of moxonidine provided significant reduction in the setting of systolic BP and diastolic BP. So even when this moxonidine was started as a single drug in borderline hypertensive, in obese people, or in an young hypertensive, this definitely proved beyond doubt that it can bring down BP to a significant double-digit reduction. So we have till now we have seen in end-stage renal disease moxonidine as monotherapy, and in some subgroup of people as monotherapy. Let us look at how moxonidine can probably come handy when you're dealing with people and when you need to combine these drugs with other drugs. Here is a group of elderly hypertensive. Use of moxonidine as an add-on treatment in elderly patients who have a significant who have a specific age-related problem with isolated systolic hypertension was studied. So you all know that elderly people, either because of pseudohypertension or per se because of their vascular stiffness, they may have isolated systolic hypertension, and any amount of drug, other class of drugs, probably fails to reduce this isolated systolic hypertension. When you add on moxonidine, a centrally acting drug, definitely there was a double-digit reduction in the systolic BP seen in these group of people with very less side effects. This is exactly the diagrammatic or the chart which represents the effect of moxonidine on elderly patients. Okay, this is a topic study. This is to find out the efficacy of moxonidine in combination in treating essential hypertension. I told you essential hypertension is no longer used for the reason I told you. It is no longer essential. It is primary hypertension. The number of patients which were included was 566 at 138 centers in UK all over, over a period of 12 weeks. All the patients had not responded to earlier medication use. Results, 52% of the patients, almost 294 patients of the 256 shown a reduction of BP to a tune of 17 to 13.4 millimeters to the moxonidine monotherapy. In 48% non-responders, a combination with amlodipine offered greater response with 46.9% of the patients achieving target goal. What does this mean? It means that when you start somebody with a centrally acting drug, and if you do not find adequate response to this monotherapy, adding a calcium channel blocker, because we don't prefer beta blockers because already we have stopped the sympathetic outflow. So it is probably logical to add other class of drugs. It can be ACE inhibitor or a calcium channel blockers as a first add-on therapy. So vice versa, if you extrapolate the study, probably if the patient is on amlodipine, and if you think that there is a compelling indication that you may not be able to use an ACE inhibitor or a beta blocker, then adding a moxonidine can definitely bring down the BP. There are a lot of clinical situations where probably we may be forced to skip certain group of antihypertensive drugs. For example, people who have renovascular disease, it is very, very difficult to very confidently use ACE inhibitors or ARBs. People who have hyperkalemia, electrolyte imbalance, it's very difficult to continue with ACE inhibitors and ARBs without adequate monitoring. Beta blockers, though highly selective beta blockers are safe in bronchospasm, still people who have high degree of bronchospasm, COPD, very bad obstructive airway disease, we have some reservation on starting high dose beta blockers on these patients. So we are left with no other drug apart from a good calcium channel blocker with a centrally acting drug. This is exactly the representation of that study by way of when you sequentially add drugs. Here probably moxonidine was added with amlodipine and enalapril and even diuretics, has produced a significant drop in the BP setting. What is CAMA study? It is a post-marketing study to find out the efficacy of moxonidine in patients suffering from metabolic syndrome over 8 weeks. Quite a sizable number, almost 4,005 people at 772 participated in this study, which was conducted in Germany. There was a remarkable reduction, almost to a tune of more than 20 millimeters of mercury was observed. The reduction in BP increased with the severity of the disease, which means that the higher the BP, initial BP, there was a greater reduction. Somebody presenting with almost 180, 100, they had a significant drop in their BP with centrally acting drug than people who had a borderline BP. Suppose somebody presents with only 140 asystolic concentration, probably the reduction was only to a tune of only 10 millimeters of mercury. Whereas somebody presented with 160, 180, the fall was more than 20, 25 millimeters. So the centrally acting drug probably also balances within itself to reduce, to bring to only an optimal level, not a dose-dependent reduction, straightaway reduction of more than 20 in all group of people. So probably there seems to be some kind of a safety profile on this patient, this subgroup of patients and drugs also. This is the diagrammatic representation of the study which we were talking. This study is to find out the efficacy of moxonidine in obese patients with BP control is extremely difficult to achieve in open multicentric study. Here also they found out that there was a significant reduction in the BP. As I told you, in obesity itself, which beheads the increase in sympathetic outflow, probably leads on to high BP. So in an obese person, when you suspect that there could be a high sympathetic outflow, adding a centrally acting drug as a first line of drug is probably not a bad choice in controlling BP in this group of people. This is exactly what we discussed in the obese people and who are not controlled on antihypertensive. Role of moxonidine in suppressing obesity-related hypertension. This is probably the pathophysiological mechanism by which there is probably obesity which is interlinked with the sympathetic overactivity. If you look at imidazoline receptor stimulation, which cause inhibition of the sympathetic activity, reduces the skeletal muscle vascular resistance and improves the glucose metabolism. Once the vascular resistance in the muscle, which muscle is the largest organ in the body, which is responsible for insulin and glucose metabolism, when it improves, it lowers not only the BP, it also improves the insulin resistance and thereby has a positive effect on overweight, whereby it when there is an increased weight, it also stimulates the sympathetic overactivity. Whereas apart from lowering the blood pressure, it also has a positive glucose metabolism, whereby reducing the insulin resistance has some positive effect on even insulin resistance syndrome or metabolic syndrome. So the greener channel is the positive aspect of blocking the sympathetic activity. If left uncontrolled, it causes overweight and causes sympathetic overstimulation. Here, probably there is a study which on chronic renal failure patients. This subgroup of people have very resistant hypertension, and sometimes it is very difficult to use ARBs and ARB in these kind of people because they may have borderline parenchymal function, which sometimes get worsened when you use high dose of ARBs and ACE inhibitors. So we have lost one class of drugs to be used for these kind of people, and we are left with only a beta blocker, probably an alpha blocker, diuretics plus or minus, unless otherwise it's a strong loop diuretics. We are forced to use centrally acting drugs, which has been proved, as we have seen in the previous study, that it has got a very good effect on improving the BP control. And in another study, it also was seen to reduce almost microalbuminuria to a tune of almost 24%. It does not, probably in my opinion, does not have a direct effect on the renal system to reduce microalbuminuria. Simple logical reason is, if you have a good adequate BP control, your microalbuminuria is going to start coming down. Because one of the important strategies to bring down microalbuminuria is good BP control and adequate glycemic control, which you can achieve by using a centrally acting drug. This is the probably a statistical representation of the previous study which we were discussing, the same study. So why do you say that are all centrally acting drugs the same? Can it be compared with other centrally acting drugs? Yes, it was compared. This is compared to the antihypertensive efficacy of the second generation centrally acting drugs, moxonidine, with the first generation, which is clonidine. The results after the withdrawal, maybe they had a similar effect, but after the withdrawal of the moxonidine, BP rise gradually to a base level in 3 days against sudden abrupt BP rise, which is seen in clonidine. So there is a risk of rebound hypertension, which we already discussed, which is probably adds to the safety profile, apart from being less sedative and causes less dryness of mouth and other effects by the newer centrally acting drugs like moxonidine. So when you compare moxonidine with clonidine, yes, definitely the side effect profile is much better with moxonidine. Apart from that, there is a safety profile which adds an edge to using moxonidine. This is a crossover study. There is a double-digit reduction in the BP reduction without a rebound hypertension in group of moxonidine patients. So what is our experience? Moxonidine is safe, effective antihypertensive with considerably improved tolerability compared to earlier sympathomimetic. Least adverse effect profile. This is a 20 phase 1 studies have been done to look at the adverse effect, that is the sleepiness and dizziness are dose dependent or less frequent with the dose. If you could titrate the dose appropriately, the maximum acceptable dose with adequate effective BP control, probably even the minimal side effect profile can be nullified. There were 30 trials in the last 15 years. 8 trials against a placebo confirms no serious drug-related adverse effects. So, moxonidine when you look at the side effect profile, it is comparable with the placebo. It is equal to giving to a placebo when you look at moxonidine, and definitely it is proved to be effective, much more effective than a placebo, superior to clonidine, and it has got a least withdrawal effects. So moxonidine does not have a rebound hypertension like what you have in first generation. Plus, moxonidine can be easily combined with other antihypertensive drugs without any major drug-drug interaction. So here, probably in a metabolic syndrome, they have looked at intervening at the diet level alone with Moxovas, which is our moxonidine, and they have found out that there has been a significant improvement in the pressure profile. Apart from that, they have also found out that there is some kind of an improvement in the insulin levels also. So if you class this slide, leave all the other things. With good adequate diet and lifestyle modification, you can achieve a lot of things. But moxonidine, by reducing the sympathetic outflow, has a favorable effect on decreasing the insulin, or whereby improving the insulin sensitivity and decreasing the insulin resistance. So it has got it goes without to say that there is some pleiotropic effect of moxonidine on generalized metabolic syndrome patients also. Renal functions, this centrally acting drugs can be given to all stages of renal failure patients, even with the GFR as low as even 30. Probably you should time the dose and reduce the dosage according to the GFR level. This study, probably they have compared moxonidine with enalapril. Nothing new to say. Any drug, when it compared with centrally acting drug, which is a sympatholytic drug, has definitely a score over other class of drugs, and it is proved that it is better in BP control when compared to enalapril alone. Probably that graph is missing. Nifedipine, when compared with nifedipine, which is a time-tested calcium channel blocker widely used in chronic renal failure patients, the conclusion was moxonidine is effective and is well-tolerated antihypertensive, as good as nifedipine, without any side effects as seen with nifedipine. So if you compare the efficacy of moxonidine with nifedipine, effect-wise, it is comparable. It is non-inferior to nifedipine. When you choose between moxonidine and nifedipine, it is non-inferior when you choose moxonidine over nifedipine. But definitely the side effect profile is much better with moxonidine rather than nifedipine. They may not have reflex tachycardia and other things. Sorry about this graph which is missing. This is what we discussed. So when you start with other antihypertensive drugs, probably when you follow these patients who are on moxonidine and other antihypertensive drugs, they have seen some kind of a significant reduction in the incidence of end-stage renal disease cases, because other class of drugs probably interacts with the renin-angiotensin system and renal parenchyma, thereby predisposing those kind of people, or probably accelerates end-stage renal disease, which is probably not seen in moxonidine. What are the pleiotropic effect? Moxonidine was statistically superior to metformin in reducing the insulin concentration after the glucose. We saw in the previous slide how adding moxonidine to a diet regimen and lifestyle modification had a favorable effect on the insulin level. But when it compared with head-on with metformin, definitely it proved to be little more superior to metformin in reducing the insulin resistance. Let us talk about some Indian trials where it was an open randomized comparative trial. Amit, you can stop me because I think I am exceeding my time.
Sir, we can quickly wrap up in next 5 minutes, so that should be fine, sir.
Yeah, sure, sir. A couple of slides and I think I will be
sure, sir.
Yeah. So here, and it's an open randomized comparative clinical trial to evaluate the efficacy and safety of moxonidine versus ramipril versus losartan in hypertensive patients with or without diabetes. So here is a comparative study of moxonidine with ramipril and losartan, AC inhibitor and an ARB in hypertensive patients, probably the mixed population of diabetes and non-diabetic also. There was a significant reduction, that is almost 16.57% reduction in systolic blood pressure in moxonidine group treated patients as compared to only 10 or 10.5% reduction in the BP control with ramipril and losartan. The conclusion is probably moxonidine is as safe but more effective than ACE inhibitors or ARBs. This is a slide representing that trial. So what is the pharmacokinetic? We have seen all the benefits of moxonidine, but let us look at what happens on the clinical settings. Absorption by GIT is almost 90%, very good. Bioavailability is excellent. Food does not affect the interaction, so it is easy to be administered in elderly people and geriatric people, where you do not give them any probably instructions on taking the drug. Cross the blood-brain barrier, only 7% of the drug is bound to plasma. So it is not a very long-acting drug, and it is usually easily excreted. The T-half is almost 1 to 1.85 hours, close to 2 hours. And as I told you, it increases with renal insufficiency. So probably you should minimize the drug when you give, or space the timing when you give for renal failure patients. Maximum antihypertensive effect is observed in 2 to 4 hours after Cmax is reached, and effect persists for several hours after the drug disappears from the blood. Moxonidine, because of its pharmacokinetics, usually can be given OD or sometimes BD also. Indications. Indication is mild to moderate essential hypertension. I don't want to use the term essential hypertension. It is primary hypertension. Resistant hypertension associated with obesity, diabetes, chronic renal failure, and on people who have failed to achieve their target BP in spite of having 2 or 3 drugs. The starting dose of moxonidine should be 0.2 or 0.3 once a day, may be increased at a 3-week interval to a max of 0.6 milligram per day in 2 divided doses. So you can probably titrate your dose up to a maximum of only 0.6 milligram per day, which is you have a 0.3 dosage formulation. You can at the most give twice a day. And you should not increase a single dose of more than 0.4. That is why wisely the company has brought out only with 2 doses of 0.2 and 0.3. Even if you may not be able to increase the single dose of 0.4 milligram. At the most, you can give 0.3 at a given time, and you can only space it to twice a day, which can reach a maximum of 0.6. Pregnancy and lactation, as usual, there is inadequate data, though it has not been proved to be teratogenic. Due to lack of evidence, we usually don't use these drugs in pregnancy and lactation. The area under curve, in elderly, area under curve is increased by approximately 50%, hence lower dose of moxonidine should be used. So the bioavailability starts increasing as you age. So probably in elderly people, it is good to start only 0.2 OD and titrate if required after 3 weeks interval on a slow and steady fashion. Renal, mild to moderate renal dysfunction, that the GFR almost 30 to 60, and the single dose should not exceed 0.2 and no more than 0.4 milligram per day should be used. So whenever you see a patient with mild to moderate renal function, do not use 0.3 milligram formulation, use only 0.2. And if you want to increase the dose, increase 0.2 to BD dose, which is the maximum allowed dose in a compromised renal function. Do not use 0.3 as a thumb rule. Do not write 0.3 milligram for renal, renal patients or renal compromised patients. You start only with 0.2 and probably can increase it to twice a day at the most maximum. Influence of renal function and pharmacokinetics, as I told you. So a trial on 24 patients suggests that once daily administration of moxonidine 0.3 is well tolerated even in patients with GFR less than 30 milligrams with no deleterious in renal function as a consequence of moxonidine therapy. The trial concluded that in patients with renal failure, the dosage of moxonidine should be individually titrated for desired therapy. Yes, of course, you can use 0.3 in renal failure patients, but the caution is if you use 0.3 and by mistake, if you ask the patient to take twice a day, it exceeds the upper limit of dosage which is given for renal failure patients. that is 0.4. So you cannot cross that. So safer is to use 0.2. Even if you want to titrate to 0.3, make it 0.2 BD. What are the precautions? Cessation of combination. So when you have to be very cautious when we give combination therapy. You all know that the sympathetic outflow has both beta and alpha blocking property. So when you're using a beta blocker along with the centrally acting sympatholic drugs, beta blocker should be stopped first, and then moxonidine stopped after a few days. Why? Because if you do not stop beta blocker and stop moxonidine, there might be an controlled alpha beta dyssynergia causing either rebound hypertension or deleterious effect. Use with caution in patients with a history of angineurotic edema, severe coronary artery disease, and unstable angina. Like in any other drug with severe coronary artery disease, beta blockers which blocking can cause vasospasm, can worsen sometimes coronary artery disease or unstable angina. So caution should be on these kind of subgroup of patients before starting centrally acting drugs. Advantages: the antihypertensive efficacy is comparable to that of other class of and this we have seen. So I think let us not waste time because it's just a summary. It is a very safe drug, centrally acting drug, can be combined safely with any other class of drugs, and it can also be used as monotherapy and sometimes in compulsory indication as a start of therapy for a lot of people who have diabetes and metabolic syndrome. So this is the drug which we were talking all along, Moxovas, and with this probably I don't know whether I did justice to whatever given to me, but the slides were quite huge load which I had to compress upon. And before concluding, I would also say what is not covered here in a couple of minutes, that sometimes I have seen in my practice a lot of patients who have been referred from our dermatology colleagues saying that we have this patient where you should not use calcium channel blockers, you are not supposed to use beta blockers or ACE inhibitors like psoriasis or other skin disorders where most of the antihypertensives are contraindicated. So those group of drugs, in my personal feeling, I feel that this centrally acting drug, moxonidine, is very, very safe and does not interact with any of the drugs given for chronic dermatological issue and does not exacerbate dermatological conditions in these patients when you start this centrally acting drug. And before concluding, and I thank for this opportunity, over to Amit.
Thank you so much, sir. And I will echo the words of Dr. N. Kannan, who has said that it was a very excellent presentation. Almost all topics on hypertension were covered. And thanks for enlightening us on the clinical scenario, which will empower the physician in their day-to-day clinical practice, sir. And sir, before we end, I have a couple of questions received from the audience. Sir, Dr. N. Kannan asked that till the JNC 7, beta blockers were the first line therapy in hypertension, but now we all know that the scenario has changed. And what are your views specifically on the Indian subtype of patient, considering the landmark studies by ICMR and the recently published landmark study, and especially when they elaborated on the importance of sympathomimetic hyperresponsiveness?
Thanks, Dr. Kannan, for the nice words. But I think you should have stopped with compliment alone rather than giving such a long question and a difficult question to me. Anyway, see, till JNC 7, there was an probably importance given to diuretics and beta blockers as the first line of drugs. Till then, there were not much evidence on the importance of ACE inhibitors and ARBs. Once there was beyond doubt, there's a proof that ACE inhibitors and ARBs had a definitive role in probably retarding the remodeling of the heart and probably decreasing the remodeling of the cardiovascular system, which has a beneficial effect in retarding the incidence of cardiac failure. This probably made a compulsive indication that these kind of drugs has to be used first, because as I told you, hypertension is one of the primary cause for which leads on to congestive cardiac failure. So if you target BP alone without keeping in mind the end complication of congestive cardiac failure, you may tend to use beta blockers and other things. But if you keep your congestive cardiac failure as an end, benefit which you need to achieve, your compelling indication will move to ACE inhibitors and ARBs. In Indian subgroup population, I'm not sure which study Dr. Kannan is referring to, but our Indians do respond very well to most of the calcium channel blockers and ACE inhibitors. Some of them do not tolerate beta blockers at a very high dose, how Westerners tolerate beta blockers. In those cases, when people do not tolerate very high dose of beta blockers, but you are able to only use calcium channel ARBs, this sympatholytic drug, like centrally acting drugs, is well tolerated when compared to peripherally acting beta blockers.
Thank you so much, sir, for that insightful reply. Sir, how has been your personal clinical experience with moxonidine?
I've been using this for a couple of years now, and I don't know whether I am right in saying that my experience is vast and I can share it with people, the audience who have much more higher experience than me. But when we started using centrally acting drug like the first generation, we usually find that the tolerability was very low and the discontinuation rate was very, very high on these people when we use first generation centrally acting drug. Once we have had the second generation, now I think it was used like any other antihypertensive drug without any hesitation or inhibition. And definitely the side effect profile was excellent. People did not have any complaints on the side effect profile of this drug. And it had a very good, antihypertensive profile. Plus, it had it is so friendly that it can be just added with any drug of antihypertensive from other group. So I find it very, very handy when I get stuck with a little high BP. I'm a little, in a difficult situation to choose other drugs. This seems to be an easy way out for me.
So that was very enlightening. So that brings us to our next question. As you rightly mentioned, that in clinical situations wherein we need to control blood pressure and we do not have choice of other antihypertensive, that is one. Sir, any other clinical parameters that you keep in your mind before you start with moxonidine?
I won't say clinical indications which will favor me to use moxonidine, but there are clinical indications which will probably prevent me from using other antihypertensive. Like in chronic diabetes, when they have peripheral vascular disease, I hesitate to use beta blockers. I don't use beta blockers. So you're lost with one arm there. You don't have that choice of using a beta blocker there. Same way, when people have started developing borderline renal dysfunction, you don't have ARBs and ACE inhibitors for a convenience to use, because our patients do not follow that regularly to probably monitor the renal functions and electrolyte values. So it is very difficult to confidently start these kind of people on ACE inhibitors and beta blockers. So these set of group of people, when the BP is not under good control, the easiest and probably the safe bet would be a centrally acting moxonidine, because you don't have to really, lab-wise follow them up. Plus, it has got a very good side effect profile and it does not have any side effects pertaining to micro or macrovascular complications.
Right, sir. Thank you so much, sir. Sir, one last question from our side, sir. We know that moxonidine is at par with efficacy as compared to clonidine, but the adverse event profile is better with moxonidine. Sir, how do you as a clinician compare moxonidine to clonidine?
I told you already that when we were not used to using the second generation,
Correct,
we had a lot of dropouts of patients who were taking clonidine. They will not be able to tolerate the clonidine for more than a month or so. So they will have a lot of complaints and they were never comfortable with the first generation centrally acting drugs. But moxonidine, probably over a period of time, we almost forgot that it is a centrally acting drug. So it is such a, excellent, side effect profile is that we usually don't consider it as a different class of drugs, which has to need special precaution and other things. So we are very comfortable and very, confident in using those drugs.
Sir, that was So wonderful of you, and we thank you for sparing your time. And we were genuinely honored by your presence. And I would also like to thank the audience for the patient listening. And we really hope that the learnings today would go a long way in our clinical practice, which will ultimately lead to benefit of the patients. Sir, have a nice evening ahead.
Thank
Thank you,
you.
sir.
Thank you once again for the McLeod, faculties and staffs who had probably worked beyond their time to make this webinar a success. I hope it is a success, but not from my side, at least from the participant side. They had some benefit for probably spending or wasting their time for almost 1 hours, I would say.
Thank you so much, sir.
Bye. Thank you. Have a nice day.
Okay, Amit sir and Dr. Sudagar Singh, thank you so much. I am ending the session now.
Sure.
Okay. Thank you so
Thank,
much, sir.
thank you.